Chapter 4, Stretching for Improved Mobility. So we talked a lot about range of motion in the last chapter, which we can use to maintain range of motion and have small increases in range of motion, but we utilize stretching for improving range of motion and improving overall mobility. Stretching is defined as any therapeutic maneuver designed to increase soft tissue extensibility and subsequently improve flexibility and range of motion by elongating or lengthening the structures that have adaptively shortened and become hypomobile. Factors that can contribute to restricted motion include joint inflammation, postural malalignment, prolonged immobilization, and things of that nature. Your textbook has a more thorough outline, but these are going to be some of the more common ones that we are going to run into in therapy. When we talk about flexibility, we want to talk about how much a person can move or a limb segment can move. So we have dynamic flexibility and passive flexibility. Dynamic flexibility is how much the patient is in control of or the person can move themselves and what their range of motion and overall mobility look like when they're in control. And then passive flexibility is going to be when something else is moving the extremity or the person, how much movement do they have. Hypomobility is defined as decreased mobility or restricted motion at a single joint or series of joints, and we utilize flexibility interventions to treat hypomobility. A common cause of hypomobility and an important term to understand and learn is contracture. So contractures are a physiological state in which there is adaptive shortening of the muscle tendon unit and other structures surrounding a joint, including the ligaments and joint capsule, resulting in significant resistance to stretch and limited range of motion. We designate the contractures based on where they are. So if somebody has restricted elbow extension because of a contracture in their elbow flexors, we would call that an elbow flexor contracture. Contracture versus contraction, they are not synonymous. So contracture is adaptive shortening of the muscle units. Contraction is the active shortening. And so holding a contraction for a prolonged time may eventually result in a contracture, but a contraction is not the same as a contracture. We have several different types of contracture: myostatic, pseudomyostatic, arthrogenic and periarticular, and fibrotic and irreversible. And really the main difference that we need to understand in those is that the fibrotic and irreversible, we're not going to be able to do much to affect unless we are willing to cause tissue damage. And so that's going to be patient specific. A lot of times as therapists, we have to be selective in the tissues that we stretch because patients utilize inherent tightness in muscles to make up for weakness, because a tight muscle doesn't have to be a strong muscle. And so if a patient is too weak to support and provide the stability at a joint that's needed, muscle tightness can occur to promote that stability. And so sometimes in therapy we can't stretch a muscle until we're ready to stretch it because we've developed the dynamic stability around it. Other times we will use selective stretching to maintain function at other joints. So basically selective stretching is where we allow hypomobile structures to develop to improve function. So we allow tissues to shorten and joints to have decreased motion in order to improve function in the patient. This is where we balance mobility versus stability for function, where an increase in mobility is going to result in a decrease in stability, and so we have to make sure that we maximize patient function in whichever direction that needs to go. So we use selective stretching. One of our primary examples is going to be maintaining the finger flexor tension in patients with spinal cord injuries in order to maintain a tenodesis grip. So if you'll remember in kinesiology, we talked about how the wrist flexors and finger flexors the finger flexors also cross the wrist, and so patients following spinal cord injury who don't have active finger flexion, so above C8, but they do have active wrist extension at C6, they can utilize that active wrist extension to cause curling of the fingers to develop a grasp, and that can only be maintained if we have tension in the finger flexors. If we stretch those finger flexors, we don't get that inherent grasp. It doesn't get tight enough to actually grasp objects. Overstretching and hypermobility can kind of go hand in hand, to where if we stretch too far, we cause increased mobility compared to the normal range of motion. Hypermobility does improve function in some circumstances, especially if we have hypomobility at another region that we need to compensate for. but we typically only utilize hypermobility in very patient-specific circumstances. There are a couple different types of stretching that we can do for patients, and so manual and mechanical stretching is going to be passive or assisted stretching. Typically, that's going to be performed by the therapist applying the stretch or utilization of external devices to apply a passive stretch where the patient isn't causing any of the motion themselves. Self-stretching can be utilized where the patient engages in some degree of the motion and then has either a supporting extremity or an external support to passively push for increasing that overall flexibility. And then neuromuscular facilitation and inhibition techniques, PNF stretching. We'll talk about those a little bit here, but we're going to dive into them deeper in neuro. But that's where we utilize the neuromuscular system to help improve the function of the musculoskeletal system by inhibiting muscle activation in areas where we have increased muscle firing that restricts range of motion and promoting muscle firing in the opposite muscle groups to help improve range of motion. Muscle energy techniques can kind of tie in with PNF as a type of PNF intervention, but muscle energy techniques are where we utilize an isometric contraction to further enhance tissue elongation. So we get a post-isometric relaxation of the muscle that allows us to stretch a little bit farther. We can also utilize joint mobilizations or manipulations. In the state of Oklahoma, PTAs are allowed to do grade 1 and 2 joint mobilizations, and you guys will learn those in clinical procedures. Soft tissue mobilization and manipulation can also be performed where we focus instead at the joint level at the soft tissue structures, whether that be the tendons, ligaments, or muscle bellies themselves. And neural tissue mobilization to where we can utilize neural glides and things of that nature, which we will talk about more in the peripheral nerves lecture. So when do we want to use stretching? I apologize for the phone ringing, so I'm just going to start over. So indications for stretching. When do we want to do it? So we want to provide stretching when patients have adhesions, contractures, or scar tissue that limit range of motion, because we want to try to decrease the restriction from those adhesions, contractures, and scar tissue and break it up a little bit. When there's potential for structural deformity and their diagnosis or treatment is limited by the range of motion, so if we have range of motion restrictions that are causing further deformity at other joint segments, we really want to make sure that we're addressing the flexibility at the joint that's causing the deformity. We want to stretch when there's muscle weakness and shortening of muscles, though we need to be sure that we are not taking away the inherent stability that the muscles are providing by being tight by stretching weak muscles. We want to make sure that we incorporate it as part of a total fitness program and before and after vigorous exercise to help decrease muscle soreness. When do we not want to provide stretching? When is it contraindicated? So stretching is contraindicated if there is a bony block at the joint, when there is a non-union fracture, when there is acute inflammation or infection, when there is sharp or acute pain with elongation of the tissues, when there is hematoma or tissue trauma present that the tissue needs to still heal from, when there is hypermobility, we don't want to stretch because that's definitely not indicated, and we don't want to stretch hypomobility that provides stability or control. You can reference box 4.2 in your textbook for more details on each of these. We know when to stretch and we know when to not stretch, but why do we want to stretch? So potential benefits and outcomes are going to include increased flexibility and range of motion, which can tie into improved function. We can improve general fitness through stretching and flexibility. And other potential benefits are going to include injury prevention by reducing risk from improper joint mechanics, reduced post-exercise muscle soreness, like we talked about when we utilize to reduce delayed onset muscle soreness, and we can also see enhanced performance as a result of the improved muscle length tension relationship. Soft tissue structures have different properties that allow them both to shorten when maintained in a shortened position for a prolonged time, but also allow them to lengthen when maintained in a stretch for a prolonged time. Elasticity is going to be the property that allows tissues to return to their normal resting length. Plasticity is going to be the property that allows tissues to achieve new lengths, and viscoelasticity allows tissues to resist change unless the force is sustained, and this is only seen in non-contractile connective tissue. The mechanical properties of soft tissue structures, so basically how they are composed, is going to affect how they work as well. So if we look at the mechanical behavior, parallel fiber types resist tensile load, and so they can withstand a greater pull along the length of that tissue. Uh, soft tissue types that have varied fiber orientations resist in different directions, and so they can experience a lot of rotary motions and pulls in different directions without having damage. And the composition of the soft tissue type is going to indicate what type of stress it typically experiences, and fibers end up aligning in the way that they need to resist best. If you look on page 93 at the stress strain curve, you can see how connective tissues respond to stress. So stress is going to be defined as the force per unit area for this curve, and strain is the amount of deformation or lengthening that happens. So the stress strain curve illustrates the mechanical strength of structures and is used to interpret connective tissue response to externally applied loads. Essentially, we can see that tissues have a length that they can stretch naturally and still have elasticity from and return to normal resting length. And then they get pushed to a further point where the stress increases to the plastic range, where that change becomes more long term, and eventually they reach a failure or breaking point. There are different types of stress that we're looking at when we're talking about this stress strain curve or any stresses on the body. And so understanding the difference between the types of stresses is important. So tension is going to be a force that's applied in a manner that will lengthen the tissue, so it pulls and causes tension through the tissue. Compression is a force applied in a manner that approximates the tissue, so that's where we're getting the tissues pushed together and squished. Weight bearing typically compresses our joints, and so that's where we see compressive forces. And then shearing is where we have two or more forces applied in opposing directions, resulting in increased friction. And we can think of skin breakdown as where we most commonly want to avoid shearing forces, but we also need to avoid shearing forces at the joint level, especially looking at alignment and stabilization when applying stretches. We can see changes that happen in collagen that affect the stress-strain response, and those effects can be from immobilization, inactivity, age, corticosteroid use, or injury, or we can also see it from poor nutrition, hormonal imbalances, and dialysis. But essentially, the changes that we're seeing happen in that collagen is that it's getting stiffer, and so it decreases the elasticity portion of that stress-strain curve and reaches its breaking point at an earlier level of stress. We can see changes that happen in the contractile tissues as well, so looking specifically at the muscles. The figure on the right here is going to be representative of our sliding filament theory. And when we're immobilized for extended periods, we typically have one muscle that is held in a shortened position and one muscle that is held in a lengthened position. And either way, we know when we have a muscle that is too long or too short, we don't have good cross-bridge connections for normal muscle strength. So a muscle that is fully stretched, we can see at the top, doesn't have enough myosin heads to reach to connect to pull the rope. In a relaxed state or moderate contraction, we have the ability to move still, and there's enough connection space for the cross bridges to form and generate the force that we're looking for. But when we're in a shortened state or maximum contraction, we have crossover or layover of the different bridge levels, and so we can't make good connections. And so I would understand this figure and be able to determine if a muscle is in a stretched position or a contracted position based on these images. We have special sensory receptors in our muscles that help to give the body specific information about what's happening within the muscles. And we talked about these a little bit in kinesiology when we looked at deep tendon reflexes, that we have to have activation of the muscle spindle in order to activate a deep tendon reflex. So the muscle spindle senses quick and sustained stretches, so that quick stretch when we're hitting with the reflex hammer is what activates the reflex response. But muscle spindles are also the reason that when we apply stretches, we need to do so slowly so that we don't get a reflexive contraction in a muscle that we're trying to stretch. Our Golgi tendon organs sense the tension in the muscle tendon units, the neurophysiological response of muscle to stretch. So we've got the stretch reflex that can be activated that inhibits the ability to stretch targeted muscles. This is why we want to use slow, low intensity, prolonged stretch to avoid triggering the stretch reflex. And then we also look at autogenic inhibition, and that comes more from our Golgi tendon organs that are able to sense tension in the muscle and promote relaxation within the muscle to allow for more of a stretch. There are several factors that we need to look at in applying stretches and going through them here, determinants and types of stretching exercises. So alignment and stabilization. We need to make sure that the limb segments can be aligned properly to pull the muscle in the correct direction when we are stretching so that we are going in the opposite direction of the muscle's line of pull. We also need to have stabilization of the proximal structures so that the origin point doesn't just move with us as we stretch, but that it's held in place to allow stretching along the length of the muscle. The intensity of the stretch, or how much of a stretch we're having the patient push into or we are pushing the patient into, needs to be determined based on patient response to stretching and patient-specific needs. We can look at duration of stretch, and that's going to come down to the different types of stretches that we can do. So static stretching is a prolonged hold of a stretch. Static stretching typically looks at having a stretch hold of 1 to 5 minutes, compared to cyclic intermittent stretching has a hold of 30 seconds to 2 minutes in repeated cycles. There's not much difference between static stretching and cyclic or intermittent stretching other than substantially prolonged stretches over 2 minutes are going to be qualified as static stretching. Our static progressive stretching is going to be where a stretch is held for a long time, but as the stretch is held, the person tries to move deeper into the range of motion to increase the stretch on the muscle as they hold through the duration of the stretch. With any duration of stretch that we are utilizing in physical therapy for the majority of our patient populations, we want a low load, long duration stretch because that's the safest form of stretch, and the recommended length of 30 to 60 seconds. But if we are stretching the older population that has decreased elasticity in their connective tissue, we want to have a stretch duration of at least 60 seconds so that we are able to actually effectively impact the tissues. We can also look at how we apply the speed of the stretch. And so if we remember the importance of a slowly applied stretch, we don't want to activate the stretch reflex that causes a muscle contraction in the muscle that we are trying to stretch. So slow movements, gradual movements, and low loads typically respond better. There is also ballistic stretching, which is rapid, forceful, intermittent stretch applied at high velocity and intensity. So those are those bouncy stretches. They're most appropriate for pediatric and athletic populations where there is limited risk to causing tissue trauma. It's not recommended for the elderly or sedentary patients due to the increased trauma that it causes to stretched tissues. High velocity stretching in conditioning programs and the advanced phase of rehabilitation might be appropriate, but it's going to depend on the connective tissue integrity. And then frequency of stretch is something that we can also adjust. Obviously, somebody who has excessive hypomobility, we want to advocate for stretching more often, because the more regularly we can stretch, the better off we can impact that tissue extensibility. But our recommendation is going to be for at least 2 times a week for healthy hypomobile persons. And we can also determine what's the most appropriate mode of the stretch. So is it better to have the therapist apply the stretch and be in control of the resistance that the tissue is experiencing? Do we put the patient in charge of the stretch and perform self-stretching so that they can modulate comfort and tissue extensibility? Or do we utilize mechanical stretching where there are external factors or forces involved in creating the stretch that we need? And whatever is most appropriate for the patient's needs and their current level of function is going to be the direction that we make that choice in. PNF stretching techniques involve muscle activation either of the muscle being stretched or the antagonist of the muscle being stretched in order to promote inhibition of the muscle we are trying to stretch and increase tissue extensibility. I don't want you guys to worry too much right now about the specifics of PNF techniques because we're going to dive into those more in neuro, and you need a little bit more of a foundation before I can expect you to understand these concepts fully. But understanding that hold, relax, and contract, relax are 2 commonly utilized PNF stretching techniques. Hold, relax is where we're going to have the antagonist contract for a brief isometric hold before further stretch is applied. Contract relax is where we will have the agonist contract before for an isometric hold before the stretch is applied again. And then we can also have a hold relax with an agonist contraction where we're essentially having a co-contraction of the agonist and the antagonist prior to applying a further stretch. Just like we talked about with range of motion, stretching in straight planes will only carry over to functional movement patterns so far. And so we also need to integrate function into our stretching. Not only does this help us with improving our flexibility and our mobility, but it allows us to generate the strength and muscle endurance needed in the range of motion required for that mobility. We want to use our increased mobility for functional activities because without functional use of the newly gained range of motion, the tissues are going to gradually return to their shortened length. So this is a use it or lose it situation where after we stretch a muscle and we get things into where we have increased range of motion, we have to perform functional movement patterns that work the muscles into those new ranges so that we can develop the appropriate motor control and muscular strength for stability of the joint. When going to apply stretching interventions, we use the exam and eval of the patient to determine what muscles or muscle groups need to be stretched so that we can appropriately apply them. When we're preparing for the stretching, we want to make sure that we set up the patient to stretch them in the correct direction. The direction of the stretch is exactly opposite the direction of the joint or muscle restriction. So, for example, we move the patient into external rotation to stretch the internal rotators of the hip. So if we have a restriction into external rotation because of tight internal rotators, we're going to stretch by pushing and moving the limb segment into external rotation, which will cause tension through the internal rotators of the hip. Another example we can look at for the upper extremities is that we stretch the elbow flexors to increase elbow extension. So if I have an elbow flexion contracture, I need to stretch into extension, putting tension through the elbow flexors in order to increase that range of motion. So the direction of stretch is exactly opposite the direction of the joint or muscle restriction. In order to apply the stretch, we want to make sure that we stabilize proximally and move the distal segment so that way we have the best control over the motion. Start gradually and move slowly. Hold the stretch for at least 30 seconds, 60 seconds if we're looking at geriatric patients, and release the stretch gradually. Don't just let the limb fall back to its return spot. For multi-joint muscles, we want to begin by stretching at each joint individually before stretching over both joints. Two joint muscles can't be adequately stretched unless they're stretched across both joints. So we want to start at one and then try to get full excursion at the other. So for example, with rectus femoris, we need to have at least a neutral hip, if not hip extension, after then applying knee flexion in order to get a full stretch of the rectus femoris. Flipping over to the other side of the leg for the hamstrings, we need knee extension and hip flexion to stretch, so we'll typically move the patient up into hip flexion before we then try to straighten the knee to get full hamstring stretch. Following stretching, there are a few things that we want to do or we can do to improve the effectiveness of the stretch. One of those is going to be applying cold to the stretch muscle in a lengthened position. Applying cold is going to help reduce any pain or soreness that the patient may experience as a result of stretching that tissue, but keeping it in a lengthened position prevents it from shortening back to the state it was in before the stretch. We also want to perform active range of motion, strengthening exercises, and functional exercises in that new range of motion to promote proper motor control and stability, and strengthen the antagonists in the newly gained range of motion to promote neuromuscular control because they too are operating in a different range of motion than they were before. General precautions are things to be mindful of before deciding to apply a stretch and in determining how to apply a stretch to a patient is going to be to make sure that you don't force a joint beyond the normal range of motion. We're not trying to make our patients hypermobile. We are just trying to restore normal range. Use caution in stretching patients with osteoporosis because they're at a greater risk of fracture. Don't stretch patients with rheumatoid arthritis during active flare-ups because this will cause more joint damage. Avoid vigorous stretching after prolonged immobilization. Remember, those tissues are more fragile after prolonged immobilization. They do not have the same elasticity, and so we can't vigorously stretch. We have to start low load, long duration. Progress the dosage gradually. Avoid stretching edematous tissues to avoid further damage. Avoid overstretching weak muscles, again, especially if they provide stability to an area. And protect newly unified fractures. Adjuncts to stretching interventions, or things that we can do to make stretching more effective, include complementary approaches such as relaxation training or Pilates for the patient. Utilization of heat or cold. We typically want to use heat before and cold after in most populations. There is research, though, that says patients with spasticity and rigidity from upper motor neuron lesions may benefit from cold prior to stretching for muscle inhibition. And so, again, patient-specific, using the best approach. But either way, when we're applying heat or cold, we want to apply in the most lengthened position if the goal is to increase tissue extensibility. We can also utilize massage with relaxation and soft tissue mobilization and manipulation to try to increase tissue extensibility. There are biofeedback techniques that we can utilize to help promote muscle inhibition to allow for greater muscle excursion, and joint traction or oscillation. And I would argue that oscillation is one of the more useful tools that we have when trying to apply a stretch to a patient. If we use gentle oscillations where we just kind of shake the person's limb to get them to relax, we typically are able to apply a better stretch. But when a patient is trying to maintain control over that movement, it's difficult for us to get the right alignment and target the muscle appropriately. Looking through your textbook, you can take a look at the upper extremity stretching, the lower extremity stretching figures and videos that are included in this chapter. We're going to go through those during the lab component of this course or this lecture. There are no specific figures or images or videos for neck and trunk or self-stretching techniques for this chapter because they are hit in the other chapters, and so we'll go through them when we go through joint by joint. But if you want to take a look at those in advance of class, it may be helpful. So before the next class, go ahead and find access to those textbook resources that we just talked about, those figures and videos. Review the videos in advance of class for the best preparation. Prepare your lab appropriate clothing for application of stretching techniques for class day. So don't wear restrictive clothing. Jeans probably aren't going to work out best. Wear some loose clothing that we can stretch in. And write down any questions you have over this chapter and bring to class to discuss prior to starting lab activities.